Okay, we're presenting on degenerative spinal stenosis. I'm Jackson Bannister. This is Gabby Hines.
So some of our objectives for today is to define degenerative spinal stenosis and its causes, define the signs and symptoms and the functional limitations of spinal stenosis, discuss the potential testing measures, the differential diagnosis, the rehabilitation process, the likely outcomes, and then we'll do a review. What is degenerative spinal stenosis? Degenerative spinal stenosis is described as a progressive condition that occurs with a narrowing space within the spinal cord. This narrowing can cause compression or pinching on the nerves of the spinal cord, which can cause back pain or nerve issues like sciatica. Spinal stenosis is more often seen in the cervical and lumbar regions of the spine, and this condition is fairly common and affects up to 95% of people from the age of 50 up, according to the Cleveland Clinic. So this is just a depiction of the lumbar spine, and we can see that there is a narrowing of the joint space, which is causing compression on the spinal nerve and the spinal canal. So the pathomechanics. Spinal stenosis can occur due to many different factors, and it's related to spinal cord dysfunction from both mechanical compression and degenerative instability. Stenosis can be categorized as primary is congenital, and then secondary is from degenerative factors or trauma. So degeneration can occur when there's narrowing of the central canal and lateral recess from the posterior disc herniation. This can occur due to age-related changes in the spine. Arthritis is another common cause of spinal stenosis, and as stated in my previous osteoarthritis presentation, osteoarthritis is a degenerative joint disease that can lead to further disc degeneration and enlargement or overgrowth of bone, which can narrow the central and nerve root canals, which would lead to stenosis. Another condition that can lead to narrowing or misalignment of the spine are tumors, fractures, scoliosis, and Paget's disease, which is a chronic disorder that can cause bones to grow larger and weaker than normal. So here are some of the clinical manifestations and the functional limitations. So some signs and symptoms include pain in the neck or lower back that can extend down the legs and foot, which is called radicular pain. A feeling of numbness and tingling in the buttocks, leg, or foot. Weakness in the arm, hand, leg, or foot. And then some of these signs and symptoms can lead to functional limitations, such as the inability to stand or walk for long periods of time, the inability to balance, difficulty completing tasks with your hands, such as writing, buttoning your shirt, or using utensils.
So some of the tested measures, x-rays can often show the narrowing of the osseous structures and possible causes for this, like maybe some bone spurs that are causing narrowing. Those would show up in an x-ray. It's important to do good observation and palpation exams to check for any dysfunction or malalignment. Active range of motion, and including your repeated motions. Repeated motions is probably one of the more important testing measures we'll do in the clinic for this disorder. Dutton details the 6th position test on page 1362. It's just a test, you can read more about it, that has, you're having your patient go through multiple positions and seeing which positions might provoke or relieve pain, similar to repeated motions. MSTT, during doing neurological screening, like your deep tendon reflexes, checking myotomes, maybe doing some neurodynamic stuff to see what might be compressed due to the narrowing of the canal. Joint mobilization to check for quality of motion, doing CPAs and UPAs of the lumbar spine. Traction can sometimes give you kind of an idea of what might be limiting motion in the spine. And then functional mobility tests, always bringing it back to functional work. A good questionnaire that was outlined and done is the OLBDQ, or the Oswestry Low Back Disability Questionnaire. This will just help you when you're going back to more objective measures to see how treatment is lining up down the road. So differential diagnosis, there are several diseases that show up similar to ours, like meningeal irritation, just the 3 layers of tissue that protect the spinal cord becoming irritated that can cause some localized symptoms that are similar to our disease. Nerve root impingement, this can actually follow narrowing of the canal, so it's important to check for nerve root impingement and check for what could be the cause for the nerve root impingement, because it may not be narrowing of the canal, it may be a different factor that we've outlined in other pathologies. Dural irritation, similar to meningeal irritation, just that localized pain. Lumbar disc herniation, spondylolysis and spondylolithiasis, which we talked about last week. Possible modalities, this is also a disease that's can be very variable depending on severity of the narrowing of the canal, and age could have a big factor on how long these treatment plans will take. But just for a rough outline, 1 to 2 weeks in the maximum protection phase, where you're doing a lot of manual hands-on stuff, a lot of posture education, that's really big, just teaching them to be aware of how they're sitting, standing, what kind of activities they're doing and how they're doing them. You can do some UBE work to focus on posture control and core stability, translational stabilization exercises, and some light hamstring stretching that could help with the pelvic tilts. For the controlled motion and moderate protection phase, the next 2 to 4 weeks doing those pelvic tilts, like progressing into that. Doing body weight trunk stability exercises. Treadmill walking was something that Dutton highlighted particularly for this disorder. Light regional resistance training just around the areas to strengthen. And then the return to function and minimum protection phase. Dutton also highlighted the Williams flexion exercises. These are used to avoid too much lumbar lordosis and improve stability of the low back and decrease pain. They include pelvic tilts, single knee to chest, double knee to chest, sit-ups, squatting, stretching, and lumbar flexion. And then doing bridging exercises and some rotational exercises once they're able to progress to those. So this is a degenerative pathology for the secondary factors. It can be slowed with proper interventions, and you can actually help with helping them get back to function and decreasing their functional limitations by decreasing pain and their mobility, and teaching them about their posture and how that affects how they're able to do these things and how they're able to stay out of pain. But many patients, depending on how severe it gets as they get older, may opt to undergo surgery. The surgery I found was an autogenous intertransverse bone graft that had as high of a 85% satisfaction rate. And with about, in most cases, about 6 weeks of proper interventions, we can kind of limit and help our patients get back to their normal function and stay in less pain. Kind of an overview of what we've talked about. Degenerative spinal stenosis is characterized by the narrowing of the spinal canal and compression of spinal nerve roots due to that narrowing. Degeneration of the lumbar disc due to aging. Patients often report radicular pain and numbness and show signs of muscle weakness and limited range of motion. These patients oftentimes struggle with ambulating, standing for an extended period of time, and extending the spine. Depending on severity, patients usually undergo about 6 weeks of physical therapy.
Devon, Have at it. Which two would you eliminate?
C and D.
You eliminate C and D. So she's eliminating C and D. Tell me why.
For the maximum protection phase, so you wouldn't do sit-ups because you're not gonna have them laying on their lumbar spine. And then posterior pelvic tilts also. You want to do that exercise.
So what would you choose?
I would choose A.
Devon would choose A. Why?
I'm imagining the position in my head, so prone, propped on your elbows, I feel like that would put a little bit of strain on the lumbar spine.
So read the question again.
So which of the following interventions should the PT recommend for a patient diagnosed with lumbar spinal stenosis in the maximum protection phase? I still choose A though, so I don't know.
Okay. So tell me, give me your rationale for choosing A.
So prone lying with the pillow under the waist, I feel like that would take pressure off of the lumbar spine. But if they were prone, propped on their elbows, the position I feel like would emphasize the lumbar spine curve. So I feel like it would make it work.
Okay. So, all right, we got a conundrum going on. So prone lying with a pillow under the waist. So they're still in prone, right? They're still in prone. What is prone gonna do to the lumbar spine? It's gonna place it in extension. Now, with the pillow under the waist, it's gonna help it bias it into a little flexion, but not much. It may just make prone line more tolerable. Okay, it may bias it into a little flexion with a pillow propped up under the waist. Okay, now you said prone popped on elbows. You wouldn't choose that one, right? Okay, why not?
I just feel like it would be uncomfortable for them.
Okay, yeah, because it's gonna reduce the space even more. So it's gonna close it even more because they're even in more extension when they become propped on the elbows, right? And that's probably likely gonna produce symptoms if they have spinal stenosis because it's gonna close the intervertebral foramen even more. All right, posterior pelvic tilts. You ruled that one out. Why did you rule that one out?
Pressure on it. Because if you're doing a posterior pelvic tilt, you'll be laying on your neck or spine.
Okay, what is that gonna do to the lumbar spine? Do you know?
It'll put it in flexion.
You said we'll put it in flexion? Okay, but you're gonna rule that one out.
Yeah, just because I feel like it'll be laying on the back, so I don't think they have like that.
Okay, and you ruled out sit-ups. Why did you rule out sit-ups?
Straight.
Okay, all right. Now, Kiki. Let's see what Kiki would choose as the best answer. So Devonna chose A. What would you choose as the best answer?
My first mind told me C.
Your first mind told you C. Why did your first mind tell you C? How many minds do you have? All right. She has a lot of minds because her first mind told her C. All right. So, all right. So let's see what your first mind is thinking.
Because I'm thinking that if I'm doing a posterior pelvic tilt, it's going to put it in flexion.
And so what is flexion going to do?
It's going to be relieved. It's going to relieve it because with the position they are stuck together. So when I flex, it's going to, I don't know how to explain
Open.
it, but
So it's going to open and increase the space of the intervertebral foramen.
Yeah.
All right. So now it's going to get the spinal nerves more room to move. Is that what your first mind is saying? Okay. So before we move and switch to Kiki's response, anybody in agreement with Devonna's answer, raise your hand. If you agree with Devonna's answer, raise your hand. right, nobody's on board with Devonna. We'll see who's on board with Kiki. So I'm gonna switch this out. So Kiki, you gotta tell me, why did you rule out the other ones? Cause this is how your test taking is. So you chose C, I'm gonna circle C. Why did you rule out A?
I ruled out A and B because they're prone.
Okay, she ruled out A and B because they're prone. And what is prone gonna do to the lumbar spine?
On the flag.
So it's gonna make it, it's gonna put an extension. So therefore it's gonna decrease the spacing of the intervertebral foramina. All right? Now, why did you rule out D?
Because there's a max protection.
Good job. So sit-ups are gonna be a little bit more aggressive than posterior pelvic tilts. So you may have to progress them to sit-ups. So it may be that they do partial sit-ups, but not a full sit-up, okay? So now if this said partial sit-ups and this was another answer, then partial sit-ups would have probably been your answer, you see? So yes, you can remove this out. So I gave this type of question because now you gotta pay attention to this. All right? It's just that simple. This is how your intervention questions are gonna be on the exam. I'll say you might have struggled with that on the first exam because you had to extrapolate content. You have to extrapolate what you know. You have to apply what you know. So many students struggle with the application component on written exam 1. So now, Devonna, you got to go back now on all of your conditions. You got to go back and look at all of these conditions. What would I do? What would I not do? And you have to study them in that way. Okay. All right. Any questions about that?
I had a question on that.
Yes, sir.
So for A and B, would you not also rule them out just because they're not interventions themselves, they're just positions?
So those positions are interventions. Those are interventions. So you have what you call extension principle exercises and flexion principle exercises. So Williams flexion exercises are flexion principle based exercises. So you have extension principle based exercises for those who may have like a bulging disc and they have pain that exacerbates and produce symptoms with forward bending. Then you're gonna go with extension principle based exercises, which starts with prone line with pillow under the waist, then prone line, then propped on elbows, then pushing up through the hands prone, then going to quadruped. You know, those are the positions for symptoms that are gonna be increased with forward bending if someone has something like a bulging disc pressing on the spinal nerve root. All right. Now, if someone has spinal stenosis, likely they're going to benefit from a flexion principle based exercise. And those are what Jackson went over with the Williams flexion exercises. So now you got to go back and look in your book. You got to go back and read that and go to the section that talks about extension principle based exercises. And it's going to list the prone line, prone propped on elbows, prone push up. It's going to list those as interventions. So those are interventions. Okay. So that's a good question, good observation. All right. Any other questions? Yes, Kendall.
Okay, so if you're doing a posterior pelvic tilt and you're supine, you're pushing, like you're gonna tell the instructor to like flatten your back.
Okay, come here. Lie down. Right here. So I'm gonna place my hand under your lumbar spine and pelvis. Okay. You feel my hand? Now what I want you to do, I want you to squeeze your abdominal muscles and squeeze your gluteal muscles simultaneously. All right, relax. Now squeeze your abdominal muscles without squeezing your gluteal muscles. See, she's having a hard time doing this. She's having a tough time recruiting. All right. Squeeze your abdominal muscles. okay? Squeeze your abdominal muscles and your gluteal muscles for me. So what I feel you're going into an anterior tilt. You should be going into a posterior pelvic tilt. When you squeeze it, there we go. When you squeeze your abdomen like that, yes. So when you squeeze your abdominal muscles, the abdominal muscles actually, when they contract, they cause your pelvis to posteriorly tilt. And so what happens is your lumbar spine goes into a more flexed position with the posterior pelvic tilt, okay? And so that's what's happening with the posterior pelvic tilt. Lumbar spine flexes more, goes into a more flexed position. So, yes. All right.